Hello, my name's Dr. Alan Fletcher and I'm here to tell you about medical examiners. The purpose of this short talk is to give you a little bit of background, to tell you what a medical examiner system looks like and what it is a medical examiner does, and also to give you some information about the introduction of the non-statutory system from April 2019. A little bit about me. I am a medical examiner of the documents and cause of death in Sheffield, and I have operated in that role for 10.5 years now. It's been a long time coming as this particular reform, but it is good to see progress being made. I am also a practicing consultant in emergency medicine and acute medicine, and I also chair the Royal College of Pathologists Medical Examiner Committee. I sit on the Department of Health and Social Care's Death Certification Reform Strategic Programme Board. As you know, the intention is for the non-statutory system to be introduced from April 2019 to include deaths not investigated by a coroner. The announcement came to explain that the system will sit within the NHS with lines of accountability to be decided and explained further. This talk is not about the policy aspects of this, but I will touch on how a system may work in an area near you. The medical examiner system is all about the bereaved. It must have the bereaved at the centre of its purpose. This is a rich picture that shows what happens after somebody dies in England and Wales. If you could put yourself in the shoes of a newly bereaved person who's naive to the steps involved, I hope you could appreciate how challenging it must be to try and navigate your way through this. In addition, there are plenty of places where this could not go well, and the purpose of the death certification reforms is trying to make sure, as far as one can, that the system runs smoothly so that the bereaved have a more positive experience of working through this. The medical examiner system has its origins in recommendations made by Dame Janet Smith in her inquiry report into the murders committed by Harold Shipman. In 2008 and onwards, the blue dots here represent the pilot sites, including faith community areas, as well as the Sheffield and Gloucester continuing as implementation resources. Several of the pilot sites have continued as early adopters as well, and they have been joined by numerous other places adopting the medical examiner system early, and they're represented by the orange dots here. It is quite remarkable that a policy has been adopted before it became mandatory to do so. I think this tells you a lot about how the medical examiner system is effective and works to serve the needs of the bereaved. As part of the pilot site, Sheffield has reviewed the deaths of over 26,000 cases now, and we have become an embedded part of the death certification process in the city. We include some community cases, but have been largely focused on the acute hospital trusts, and that is how the early adopter sites have been working. For practical reasons, it is likely that the majority of deaths in the non-statutory system from April 2019 will involve acute hospital cases. Let us now turn to what a medical examiner's purpose is. This is actually elegantly simple, and a medical examiner seeks to answer three simple questions. First of all, what do patients die from? And if we are going to therefore complete a medical certificate of the cause of death, CCD, then let us make sure that it is completed as accurately as it can be. Second, does this death need reporting to the coroner? We should not forget that the coroner has a very important role in the investigation of deaths in England and Wales, and that the coroner is dependent on timely and accurate information. So a medical examiner would want to ensure that timely and accurate referral occurs. The third question is, are there any clinical governance concerns? And if there are, then this is an opportunity to detect them and notify them early. We should just pause a moment and consider that the medical examiner's role is not to investigate. There are plenty of other organisations and systems to do so, be they coroner or clinical governance. The medical examiner's role is to detect and pass on. Here are the steps that a medical examiner must take in all cases that they are involved in that are not investigated by a coroner. It is logical that they follow in this order, but it is not mandatory that they do. First of all, there must be a proportionate review of relevant medical records. Emphasis on the words proportionate and relevant. This should not be a detailed forensic review of every entry in the medical records, because frankly that is often not required. Instead, it is a case of a senior doctor reviewing the last illness, relevant correspondence and investigation results, for example, and with the three questions: what is the likely cause of death? Does this case need to be reported to the coroner? And are there any clinical governance concerns in the forefront of the medical examiner's mind? Second, there must be an interaction with the attending doctor. It is very important that the attending doctor's views and thoughts about the case are taken into consideration. I'm going to pause here as well to explain that the medical examiner and an attending doctor should reach their views independently. Independence is a crucial part of this system, and it is essential that the attending doctor has the opportunity to consider whether there are any issues, formulate a view on the cause of death if necessary, and also then, after with an interaction, agree a cause of death with the medical examiner. It is really important to also point out that the medical examiner must not tell the attending doctor what to do. It is perhaps slightly different for cases that need to be reported to the coroner, but the medical examiner should not, for example, tell an attending doctor what to write on a medical certificate. It is, after all, the attending doctor's certificate. Where relevant, the attending doctor should be asked whether or not the case has been discussed with a senior doctor, if that's appropriate, for example, a consultant for a hospital case, and encouraged to do so. Third, and this is by no means least in the steps, there has to be an interaction with the bereaved. Now, this is a really important step. The information gained from it is pure gold. The interaction is usually undertaken by telephone, and it is logical to have this conversation after the attending doctor and the medical examiner have had their opportunities to review and discuss a case. The purpose of the interaction with the bereaved is, first of all, to inquire whether or not they understand the contents of the medical certificate, if they wish to know it. Explaining medical terminology in lay terms is often helpful to them. Ask them if it is what they were expecting to be on the certificate, and then also to ask them whether they have any concerns about the care and treatment that their loved one received. If you like, this question is the shipment question, and it would reveal any concerns they may have about the care and an opportunity to raise them early, which is the essence of a medical examiner system. The interaction is by telephone. It's a sensitive time, of course, and those making the call, whether they are medical examiners or medical examiner officers, are aware that this is a difficult, challenging time, and if people need time to reflect before having an interaction, that's perfectly okay. Similarly, there are times when people are keen to move things through quickly, and the medical examiner system needs to respond to that. The fourth step is to confirm the medical certificate where one is prepared, and in a statutory system this will form part of the registration process, but not in the non-statutory system. The key performance indicator is that the medical examiner undertakes their aspects of this work all within 24 hours of the case records being received by the office, be they electronic or paper. The medical examiner system must be configured to meet the needs of the local population, and that's something that implementation and setup needs to help those setting up the system. I hope to publish something further about that in due course, but for the moment, this is the measure, if you like, of the medical examiner system. We should also appreciate that not always an attending doctor is available straight away. They may be finishing shifts or on leave and therefore not returning to work in that way, but it does not stop the medical examiner undertaking, for example, the proportionate review. It makes sense to do that in anticipation. Similarly, if a doctor is about to finish a night shift or something like that, then that they may have their first thoughts recorded and interact with a medical examiner officer, for example, before the medical examiner, independently and not knowing the attending doctor's thoughts when they undertake their review a little later. We should appreciate that the steps 2 and 3 may be delegated to a medical examiner officer. Sorry, the text is off the end of that with the image. A medical examiner officer must be appropriately trained to undertake those steps, and there is capacity within the job descriptions for the roles to enable that. One of the benefits of having a medical examiner officer undertake those two interactions is that they may well be a permanent presence in the office and perhaps able to manage flows and queuing a little easier than a senior doctor being available to fulfill those roles as well as review records. I should point out that a medical examiner officer would defer to a medical examiner, and if there are any issues that arise from either of those interactions, then they would consult the medical examiner and discuss the case. Let us now turn to the completion of the medical certificate and formulation of the cause of death. Now, who would you like, ideally, to complete the medical certificate? Perhaps the most senior, the most knowledgeable, the most wise and astute member of the clinical team. In practice, this task is often delegated, in hospitals at least, to a junior member of the team. And I can understand how junior doctors may not get this right all the time. It's not a reflection that they have anything to hide, but sometimes if, for example, one has never done this before, there's scope for getting it wrong, and perhaps a junior doctor has come into a case after recently, within a day or two, starting a rotation, but the patient has been in hospital for, say, 6 weeks and have had complex procedures, etc. In those circumstances, they may be unaware of some of the things that have gone before. Here are a couple of examples of where things have not gone well. For those of you less familiar with formulating a cause of death, the part in the centre of this slide of the certificate is the cause of death. 1A should be caused by 1B, which in turn should be caused by 1C. Now, I understand what this doctor has been trying to get at. Through working with cases, it isn't always straightforward to formulate a cause of death, but I am afraid that this cause of death is illogical and contains modes of death that would be unacceptable to a registrar of births and deaths. This certificate would be rejected, therefore. I'm going to pause and just consider what implication that may have. It is a disaster. Consider a recently bereaved person who collects a medical certificate, sometimes in a sealed envelope, taken to a registration appointment, considering there are no issues with the case and no reason to proceed to funeral arrangements, that when the envelope is opened, which is a little bit like a parlour game, the registrar of births and deaths explains to the informant that they cannot accept that certificate, that they must stop the registration appointment at that point and refer the case to the coroner as part of their statutory duty. That is not only a dreadful experience for the bereaved, but also contaminates relationship and trust with the doctors who have completed the certificate. Funeral arrangements are go on hold, and a lot of people's time are effectively wasted. In Sheffield, that used to happen once or twice a week for hospital cases of medical certificates rejection. But since the introduction of the medical examiner system, that happens very few times in a year. Here is another certificate. This doctor has written end-stage dementia as the direct cause of death. I would question whether there is any value in adding end-stage into the cause of death in 1A. It is, after all, the condition that has killed somebody, and therefore, by definition, must be end-stage. So as a medical examiner, I would discourage words like end-stage, terminal, massive, severe. But this word causes concern to me. Malnourished may imply an unnatural kind of death. Now, there may well be circumstances where the dementia has progressed to the point where, despite everybody's best efforts, there is just no way of ensuring somebody's adequate nutrition. But this may also arise out of problems with care. It may not be hospital care, it could be pre-hospital, in a care home, for example. But either way, this wording would cause rejection again at the registration appointment. A medical examiner would need to take a view on review of the case records and interaction with the doctor, and especially interaction with the bereaved, whether there are any concerns about the care and treatment that led to this. It emphasises that the medical examiner system is a whole system approach to reviewing a patient's case. It isn't just about hospital care. It includes primary care, social care, events that are historic, falls, accidents, those sorts of things, and industrial reasons that might need coroner referral. Coroners play an extremely important role in investigating deaths in England and Wales. Medical examiners will work closely with coroners, and therefore a strong working relationship is essential. I recommend that the senior coroner for an area is closely involved in the appointment of medical examiner, at least the lead medical examiner, if not other medical examiners as well. The coroner will find it helpful to have the medical examiner's thoughts about a case when considering the legal aspects of it and influencing the decision to investigate or not. Medical examiners are not mini coroners, far from it, but what they can do is provide a distilled summary of the issues for a coroner to consider. Overall, the experience of pilot sites is that with a medical examiner's system in place, referrals to the coroner go down. This is probably, at least partly, because simple advice calls where doctors are ringing coroners' offices for advice about wording of the cause of death are eliminated. However, in Sheffield, we have seen an increase in the number of cases taken by the coroner for investigation. That includes all cases across the board. Please do not assume that this is just about problems with care. Far from it. There are industrial cases picked up. There may be deaths that have been linked to a trauma or violence, even a long time ago, that are relevant for a coroner to consider. That experience has varied across different areas, and some medical examiner sites have seen a decrease in the number of cases investigated by the coroner, or at least the status quo. I think it will depend where the baseline starts from, because there is quite a bit of variation in England and Wales regarding investigation rates and referral rates to the coroner. It is tempting to forget that the coroner has an important role for investigating deaths, because there has been so much work undertaken through learning from deaths through NHS England's programme over the last 18 months, 2 years, and that it is absolutely essential that the medical examiner system is not seen as a replacement. In fact, it is complementary instead. It isn't a replacement for the more detailed national case record review that needs to happen, but it can be the initial filter, a screening, if you like, by an independent doctor to ensure that the right cases are reviewed. In Sheffield and other places, the rate of referrals for structured case record review is between 10 and 15%. Using a medical examiner system in this way ensures independence and transparency in the process. It ensures that relatives are engaged early and that their views are taken into consideration, and they can be notified by the medical examiner or a medical examiner officer that a case is being passed for structured case record review. You can set this up early so that the transition from April 2019 is as smooth as it can be. And retrospective case record reviewers can do this role as well, but they can't do it as well as for the same case. They must be separate to undertake medical examiner work and retrospective case record review for individual cases. And finally, it avoids the embarrassment of the so-called unexploded bomb. By this I mean, with the best intentions, it's unlikely that a structured case record review will occur so quickly that it will influence the decision to refer to a coroner or proceed with funeral arrangements. Reviewing a case 2 weeks, 1 month, 3 months, 6 months down the line carries the risk, if it hasn't had an initial review, that something important is discovered, and this creates an issue not only, of course, from the need to refer to a coroner sometimes, but also involving the bereaved at that late stage when the bereavement process has already moved on. I'm going to just pause a moment and discuss independence. One of the common questions that one receives as a medical examiner is, how can one be independent? And this is particularly important now there has been the decision taken that medical examiners will be employed by hospital trusts initially, but that's emphasis on that being different from a line of accountability. Independence comes at lots of different levels. First of all, there has to be independence from the case that one is reviewing. There has to be a minimum acceptable distance. I cannot review cases that I have been involved in. A colleague would do that, and vice versa. Second, there is the rigour that will be in place for reporting about medical examiners' activities, be that their rates of referral to coroners or structured case record review. They will be subject to feedback from different agencies, such as the Coroner's Office, the Learning from Deaths programme locally. They will also undergo appraisal and revalidation. Their appraisal will be annual and their work will be scrutinised. There is the National Medical Examiner who provides oversight of the system as a whole, and they will be reporting through a process that NHS Improvement will be identifying in due course. Furthermore, there will be peer review, so there are opportunities for medical examiners to review one another's cases as part of a quality assurance programme, and the medical examiner officers play an important part in having an overview of the activity of the office and individual medical examiners as well. There needs to be clear lines of reporting at a local level. So, for example, medical examiners will have a lead medical examiner and potentially a regional medical examiner as routes to raise issues and concerns. Overall, this system will need to mature over time. It is unprecedented to have a brand new workforce of senior doctors undertaking roles that will be relatively new in many areas. Here is the process map for death certification from April 2019 for those cases that are considered by medical examiners. There will be some community cases that are not included, but this is the diagram, if you like, that represents the process moving forward from April 2019. If it looks complicated, it's because it is a simplification, actually, of a complex process. Let me first of all tell you the things that are not going to change. First of all, death will not change. Patients will still die in the same ways, the same circumstances, and the same numbers that they currently do. That it will not alter. Next, the coroner's process will not change. The coroner's office will consider cases referred to them. The coroner will make decisions regarding investigation or not, and proceed to post-mortem examination and inquest if he or she feels it's appropriate. Cremation forms will also continue from April 2019. The initial death certification reform plan was to abolish cremation forms and replace them with a unified medical examiner system for all deaths. The practicality of introducing a non-statutory system from April 2019 means that cremation forms will still continue. The difference is that for medical examiner cases, the second part of the cremation form, Form 5, will be completed by medical examiners. Registration will also continue in the way that it currently does. There is no change to the registration process. Registrars will still receive medical certificates of cause of death from informants and still have a statutory obligation to report cases to the coroner if they need to. It is hoped that as this system develops and matures, that registrars will have confidence and feel able to contact medical examiner offices and clarify points if they wish. I'm going to pause also at this point and emphasise that the cause of death list that many registration services rely upon, published by the General Register Office, is undergoing a review to make it more user-friendly and reflective of more modern causes of death. It's hoped that this will further simplify the referral processes to coroners and ensure that registration can be undertaken smoothly. The bit that is different is this bit, which is the scrutiny part of medical examiner's work. So first of all, initial advice may be provided by medical examiner officers to doctors and also by coroners, because if a doctor wishes to report a case to a coroner from the outset, if there's clearly a violent or unnatural case, then they're at liberty to do so. The scrutiny processes are those which I've already described, the 3 steps that medical examiners must consider. And if one gets to the end of that, then it may be that a medical certificate of cause of death can be issued. It may also lead to referrals to coroners or clinical governance at any point. It is essential that the medical examiner system is responsive to the needs of the local population. There are always going to be cases where there is a requirement for urgent release, if at all possible. So, for example, that may be transplant cases, children requiring repatriation, or faith community cases. Whilst a 24/7 system is unlikely to be needed in most areas, there does need to be sufficient flexibility to ensure that a medical examiner system is available to review cases, to ensure that people may proceed with their funeral arrangements without delay. In practice, the experience of pilot areas is that the process is facilitated. Accurate wording on the certificate, for example, means that problems at registration don't arise, and coroners are in receipt of valuable advice to help them whether to investigate a case further or not. The quickest that we have had a turnaround in Sheffield from the point of verification of the fact of death to the medical certificate being in the hands of the informant is 14 minutes. The medical examiner system will collect data. Here is the data set that has been collected in all the pilot areas and is continued so far. I'm not going to run through all of these categories to explain them. They're there for you to see. It is intended that the data will be entered into a digital platform on a web-based platform from all areas adopting with the medical examiner system. Just in case, because between now and April 2019 is a short time interval, just in case, we have some forms which reflect the same categories that are on these is on this list, and those are downloadable from the appropriate resources. To my knowledge, there are very few places where this information is maintained in a central location, and therefore these data are extremely valuable and a rich source of information. They help to ensure that medical examiners can take a view on patterns and trends as well. It may be one thing to have a death occurring in one circumstance, but a cluster would be detected through surveillance, the way the office is configured, and the way that the data is reviewed. A word about training now. The best way, in my opinion, of ensuring consistency between medical examiners is with appropriate training. The training is e-learning in the main, and it is expected that medical examiners and medical examiner officers will have completed the core sessions, 27 in total, of the e-learning before they start work in April 2019. The e-learning is focused on knowledge aspects such as the formulation of a cause of death, reasons to report to a coroner, the role of the coroner, and some case scenarios too. The core sessions are approximately 6 hours in duration, and they will be published as a separate resource to the remainder of the e-learning. It's worth pointing out the e-learning was created over 8 years ago now, so it's needed a heavy edit, and I have been grateful to the committee members of the Royal College of Pathologists Medical Examiner Committee a number of senior coroners and the Chief Coroner's Office in having input into the editing and review process to make this fit for purpose. It will take about 6 hours or so for a learner to complete, and this will also be supplemented by some face-to-face training, a one-day course for which we've put together some dates via the Royal College of Pathologists Medical Examiner Committee, and the purpose of those face-to-face sessions is to discuss some of the issues, challenging cases, problems, and also explore faith community and have input from bereaved organisations, etc. We have also made efforts to ensure the training is available to other stakeholders. Now, medical examiners and officers will register and achieve a certificate of completion at the end of their training, but others can register, for example, as a funeral director, a coroner, or a coroner's officer, or a bereavement services officer, or a registrar, for example, and view the training, the e-learning, as they see fit. In the last part of this talk, I thought I'd just go through a few case examples of the sorts of things that can come across a medical examiner's desk. So here's the first case. They have been anonymised and factitious, of course, adjusted from real cases, but there are no identifiable features here. A 60-year-old woman who undergoes a total knee replacement misses some prophylactic heparin injections to prevent a DVT over 3 days for reasons that are not clear. And by not clear, I mean they're not recorded in the records. Clinical features of a deterioration pointed towards a pulmonary embolus, which was confirmed, but unfortunately this overwhelmed her and death followed. Now, this case would, I'm sure, be reported to a coroner. There has been a link to surgery and so on, and a coroner would find it important and helpful to receive information about the missed doses of heparin injections. Furthermore, the organisation responsible for the case would also, I am sure, value having this brought to their attention at an early stage. Second case, this patient would be reported to a coroner in any case because death would not have occurred when it did, but for the trauma of the road traffic collision 3 years before. The devastating head injury has led causally to a premature death. The misplacement of the nasogastric tube is an important point. Now, this I would sincerely hope would have been notified through a DATIX or some other kind of incident reporting system, but not necessarily, and I'm sure that the coroner would appreciate knowing this information as well when considering how to proceed with an investigation. A third case demonstrates that one can die of a natural cause, and lung cancer is undoubtedly a natural cause in this situation, but and is really bad news in terms of diagnosis. However, it may be that further inquiry is prompted by a question and a remark from a relative in discussion, but this emphasises the importance of taking a whole system approach, because care could be exemplary at the hospital, but there may be an issue with the system that led to the radiological recommendation being overlooked. In my view, this is something that would need to be raised through clinical governance systems, of course, but also notified to the coroner to take a legal view on the case, and it's important not to lose sight of that. So in summary, the medical examiner system achieves a whole system independent review of deaths not investigated by the coroner. It has the bereaved at the centre of its purpose. There is and will be training provided to achieve as much consistency as possible, and it is integrating easily with the Learning from Deaths initiative. In my view, in short, it is the missing piece of a jigsaw of mortality review, and with a full medical examiner system, I'm sure that the mortality review system in England and Wales will be the best in the world. I thought I'd leave you with a story. A lot is made of the murders committed by Shipman, and also the scandals and investigation reports that have followed problems since, such as Mid Staffordshire, the Furness Bay, and several other recent ones, Connor Sparrowhawk's death, for example. I went further back and looked at the murders and harm committed by Beverly Allitt in Grantham. The Allitt inquiry is well worth a read because it has so many parallels to modern NHS work as well, and how this can happen in any healthcare system. At the time, the NHS responded to some of the concerns raised by the Clothier report, and I've extracted some of that information here. I agree with much of the first paragraph. It says, "From the outset we must all acknowledge, as the report does, that the tragic events in Grantham were the product of a malevolent, deranged criminal mind. Everything else must be seen in that light. The Clothier report does identify and criticise failures of management and communication in the hospital, and it is important that lessons are learned from these throughout the NHS. I agree. I do, however, disagree with the last sentence. It says, however, it refutes any suggestion that Allitt could easily have been detected or stopped. In my experience as a medical examiner, I consider that a properly functioning medical examiner system would have detected and led to Allitt being stopped much earlier than it in fact turned out." Thank you very much for listening to me. I hope this has been helpful to you. If you have further questions or want to get in touch, you have an email address at the bottom of this slide that you are welcome to contact me through if there are further things that you want to know about the medical examiner system. Thank you once again.